Okay. Okay. I'll speaking of modified approach for public education in diabetic retinopathy. As we know, successful program to combat diabetic in part relies upon the level of awareness about diabetes within the community. It appears that awareness of diabetes and diabetic is relatively low in many parts of India, making it difficult to engage in preventive actions, diagnosis, and treatment. Awareness that diabetes can cause diabetic is present in only 28.8% of the urban population in a study done in the southern India. I am present of a study in which all screening cum treatment camps were organized between November 2009 to December 2012, in which all the patients were included. All the camps were organized in the Bagpat district of the Uttar Pradesh. On the day of the camp, a mobile van equipped with the portable angiography and the laser machines was taken to the pre-decided area, in which all the diabetic patients were screened. In that examination was done, and though all patients found to be suffering from diabetic, their angiography and laser treatment was done there and there itself. As we know, there are three main approaches for the public education in diabetic. These are mass approach, which comprises of public meetings through posters, TV and radio programs, and in ads in the newspaper. Group approach through seminars and lectures, patient interactions, and group discussions. And individual approach through patient education through leaflets and individual counseling sessions. We tried all this approach by organizing press conferences, seminars, and lectures, giving articles in the newspaper, organizing patient interaction camp sessions at the campsite, and also organizing special days like World Diabetes Days. But we found that all these approaches were more useful in urban and semi-urban areas, but were less useful in rural areas. People vary so widely in their socio-economic conditions, tradition, beliefs, level of knowledge, and mixture of different approaches are required. There is lack of awareness about diabetes, and it is also lack that diabetes can affect vision. As we were doing all these approaches, we find that all these were not getting the desired result. So we developed an educational movie to impart about diabetic impart knowledge about diabetic, covering all the aspects of diabetes. This was a 45 minutes movie in which a protagonist was shown who was a diabetic, and all the procedures like laser procedure, angiography, surgical procedure were explained in great detail. This movie was shown in the rural areas through cable networks and through various aspects, and we found that after this approach, there was significant increase in the patients who were coming for the diabetic retinopathy camps. There was 50% increase in the patients of opting for the laser treatment, and thus I would like to say that diabetic retinopathy is a major cause of blindness with public health implications in India. Prevalence of diabetic retinopathy in South India over 50 years age are found to 1.3% in one study, and is going to increase exponentially in the coming decades. In a study done in Chakman Panchayat of the Ernakulam district in Kerala, it was found that literacy, these factors highlight the need for population diabetic retinopathy awareness and prevalence in diabetic studies. In conclusion, I would like to say people vary so widely in their socio-economic conditions, tradition, beliefs, and attitudes, and the level of knowledge that uniform communication approach is not viable. A mixture of different approaches must be developed depending on the local circumstances, and we have to constantly evolve new methods of screening and awareness. Thank you.
Excuse me, doctor. What was the aim of your study?
My aim was that we organized camp just to identify the patient of diabetic retinopathy and to treat them.
But here,
in this study, the aim of this study was to see the which new approach of diabetic retinopathy. We made a movie of educational movie. So we found that after showing that movie, the patients who were opting for the laser treatment have increased. Patient opting for treatment have increased. The awareness have increased.
That is for the treatment. Yes, what about the awareness?
Because as far as because the awareness increased, there only the patients came for the camps, and the number of patients who approached the camps were increased after the movie. That was
so the modification was you prepared a educational movie?
Actually, because of possible time, could not show the clips of the movie. And this was not allowed. But it was a 45 minutes movie, and it was a documentary, not a documentary, it's a docudrama in which a protagonist was shown. And from beginning, the patient was diagnosed with diabetes, but he did not opt for the treatment, and eventually he lost vision in the one eye. Then he started creating awareness in the local public. So that was like a drama kind of movie in a local language. So
was a particular area was captured for that?
My Bagpat district of the Uttar Pradesh.
Okay.
in that area only.
Thank you. Yeah, thanks, Dr. Lokesh. The next speaker is Dr. Anshika Luthra. She is not there. Okay, then we will start with the presentation by Dr. Amit Porwal. No, he is not there. Yeah, he is not there. No, so Dr. मुझे बोला Matthew is not there.
Presenting author is not here, so he will be presenting.
No, so yeah, you are the co-author. Yeah, so he will be the presenting. Yeah.
Let's start. Yeah. Good morning, judges. Good morning, participants. So my topic on the title is the predisposing factor and visual outcome in iris claw lens implantation in the high volume cataract setup. The aim is to evaluate the preoperative and intraoperative indication of iris claw lens and analyze the visual outcome in these patients. As we know, the surgical management of the FAK patients is angle support anti-jumble lens, clarification lens, and iris claw lens. Now we know the ACIL has a disadvantage of increased corneal decompensation, secondary glaucoma, peripheral NCO synechia, while SFIL has a high time consuming, have few complications like suture erosion, IR-related complication like dislocation of a lens, maybe a ciliary body damage. So the iris claw method was invented by Voss in 1980. The technique of the posterior fixation iris claw lens was proposed by Amar et al. And later modified by Moher et al. So it is a retrospective study, and the study includes the patient coming to our CAM setup under DBCS. Patient all underwent a manual SICS program. The study was conducted for 3 years for long duration. The perioperative assessment includes the routine cataract workup. Now there is no financial disclosure in this. So we have used in this study the Excel lens. It is a PMA, a single piece biconvex iris claw lens with a length of 8 mm and 5.5 mm optic size. The L power calculated with the SRKT formula. The procedure in the once the iris claw was indicated in the patient, 2 paracentesis was made at 3 o'clock and 9 o'clock. Anteriortomy was done, and then the little bit of pilocarpine was introduced. After that, the iris claw is tucked at 3 o'clock and 9 o'clock, and at the end of the surgery, peripheral areotomy was done. So the result out of total 144 aphakic eyes were enrolled in the study, out of which the 61 eyes shows the predisposing factor, while the 32% of patients has the intraoperative factors like a capsular bag delivery. So average postoperative mean BCVA in log MR chart was 0.5% while compared to the average periodic BCVA 1.3. None of the patients shows the anterior chamber inflammation, IFM or hypotony at and beyond 7 days follow-up. 2 patients was taken for re-OT for dislocation or tilting of IOL. 10 eyes shows the raise in IOP in the post-op day 1, which was managed by medically. So as you can see in the chart, the predisposing factor was most common was phacodonesis, non-dilating pupil, ZD. Intraoperative factors were like major was the bag prolapse during the nucleus prolapse, and the post-operative complication was the pupil distortion and iris chafing. Now discussion the retropupillary positioning of iris claw associated with the low risk of endothelial decompensation in the true posterior chamber location of the IOL, which lead to prominence over ACIL and SFIL over the past few decades. In our series, the major preoperative factor will lead to iris claw implantation was the phacodonesis, when the most significant intraoperative factor was lead to iris claw implantation was the capsular bag delivery during the surgery. This study was the Prodetti et al. In the study stated that the posterior PC rent was the most common cause, followed by traumatic subluxation and zonular dialysis. In a series, the preoperative mean BCVA log MR 1.3, which was significantly improved to log MR 0.5 postoperatively, and the similar finding was supported by Mansoor et al., Keller et al., and Madhavan et al. In our study, we noticed that post-operative complications like hyphema, hypotony, cystomacular edema, secondary glaucoma were resolved medically, but permanent complications like pupillary distortion and iris atrophy which could be resolved probably by better surgical technique. The Prodity et al. And Choragi et al. In the study a similar predominance of distorted and oval pupil was the most common complication, followed by iris atrophy. Meanwhile, the Mansoori et al. In the study has shown the ocular hypertension. So we didn't notice any rare complication like retinal detachment or corneal decomposition. So in conclusion, the iris claw still remain a chief solution tackling cataract with inadequate capillary support, especially among the anti-segment surgeon, which provide a satisfactory post-operative visual outcome in large camp setup. So these are my references.
Thank you, Dr. Amit. In all cases of PCR, you tried iris claw?
No, only the large capsular rent or where the rhexis margin was not able to visible or the rhexis was not complete. On the poor zonular, when the poor zonular support was there, then we tried for iris claw. The surgeon was not confident whether the anterior support is there or not, sulcus is there or not.
What was the incidence of dislocation of lens and what was the incidence of dislocation of lens and tilting of lens?
No, there are only two cases where the actually both the cases where the anterior was not done properly and the capsular tag was there. So while tucking the iris claw, the tucking was not proper because of the anterior capsule. So these two cases we have to take again in the OT and do the anterior again, remove that capsular tag, and then we retuck the IOL. So anterior was most important in this thing.
Okay. Thank you.
Okay, thank you.
Next speaker,
Dr. Satish Chadha.
Dr. Satish Chadha. Is he there? I am welcoming Dr. Malik Madam on the stage.
I'm so sorry.
We have started at 8 o'clock, Madam. First and second. First and third are over.
First and third year.
So Dr. Satish Chadha is also not there.
Who's the next?
Who is next then?
The next one is Dr. Srishti Mishra. She is there.
Is it you?
Which one?
Excuse me.
Ashish Kumar Gangurude.
Gangrade.
Good morning to all. My topic is ocular abnormalities in children with developmental delay aged between 1 and 18 years. The ophthalmic disorders are common in these children with developmental delay, and knowledge of their visual problems is essential if these children are to be given optimal support. But assessment and management of visual deprivation in these children is a complex challenge. For that, our aim was to describe the presence of ocular abnormalities in children with developmental delay, and our objective was to analyze the risk factors and systemic associations that may be contributed to delay in the development and the possible treatment that can be delivered. This was a cross-sectional study of 94 children done between September 17 to October 19. We included children with developmental delay diagnosed by pediatrician and or neurologist in the age group between 1 and 18 years. In the methodology, we included detailed history including birth history, detailed anterior and posterior segment examination including UCV and BCV were noted down. Dilated refraction after putting tropicamide or ROP drop followed by punctum occlusion was done. Glasses and low vision trial amblyopia therapy surgical correction was advised wherever required and feasible. Mean age of the study group was 5 years plus minus 4. 33 children were female and 61 children were male in our study. Out of them, 74 children had BCVA less than 6/60 in better eye, and we found fixating and following light was the commonest UCVA and BCVA in both the group. 88% children had one or more ocular abnormalities. Out of them, most common was the refractive error in 70 children, followed by strabismus in 39. Optic atrophy was the commonest posterior segment finding, and delayed visual maturation and corticovisual impairment was seen in 13 and 11 children respectively. Low birth weight was the commonest risk factor, and the epilepsy was the commonest systemic disorder in our study, and we found out that abnormal neuroimaging in 47 children. We advised visual discrimination exercises in 65 children, followed by glasses in 39. LV trial was possible in 3, and patching, cataracts, and skin surgery were advised in 12, 5, and 3 children respectively. To compare with the other studies, our results in developmental delay children were similar and comparable with a study done in India by Hegde et al. To conclude, 88% children had ocular abnormalities. Out of them, 74% children had refractive error, which is quite high than the normal kids. So we recommend that regular school screening in government and private school in both rural and urban areas. Like any other study, we have a limitation. Number one, not graded the developmental delay, and it was not a longitudinal study. Still, this study highlighted that importance of eye screening in rehabilitation centers, no adequate numbers of rehabilitation centers and unequal distribution, importance of creating awareness amongst healthcare workers and general population. Therefore, integrated approach in early diagnosis, appropriate management, analyzing the risk factor and prevention to bring about an overall development in these children. These are my references. Thank you.
Thank you. What you have highlighted there is that we need to do school screening of children.
School screening and that rehabilitation center screening, and that is also very important.
What? Sorry?
To stabilize the rehabilitation center for these kids.
Okay. No, but first of all, they have to be filtered.
Yes, ma'am, definitely.
They have to be diagnosed.
Yes, ma'am.
So, how do you suggest that preschool screening should be done? Any ideas?
In Anganwadis, we can do one thing that we are doing, ma'am, in Anganwadis.
Means
That
you are
is
training the ASHA workers to
Yes, ma'am. Yes, ma'am. For that. Yes,
screen for
yes,
vision.
ma'am. In Anganwadi, we are training the ASHA workers, and we are doing Anganwadi screening in school.
So,
and
what
that,
chart have you given them then?
ma'am, preferential looking we are asking for all the there. It is not for developmental delay kids. We are just asking them to check that visual behavior of the kids or reflex. If they found any white reflex or broken reflex they found, then
like
we are
that.
doing that. We are doing, and this study has been done in our institute only. The patient who are referred by pediatrician or neurologist.
No, I was under the impression that you all are going a step further. It's okay, fine.
Actually, it is a very broad spectrum he has selected, 1 to
Mic
18 years.
में बोलो, mic में बोलो.
So it is a very broad spectrum of the age group.
Yes.
So if you can divide it from 1 to 6, 6 to yeah, so that will be more better. Like
Yes.
In fact, I have always felt that each child needs to be screened preschool
yes,
and then again at first standard when they go from prep to first, again, and then actually every year after that. So in fact, I had this project in mind when COVID started in Aurangabad. I was planning to do it in all the ZP schools, the Zilla Parishad schools, that give them a chart, just a normal vision chart, cardboard wali, which is very cheap. And corporation was ready to buy that for their schools and train the teachers of the school to at least check vision so that we get a rough idea if there are any visual problems.
Right.
So I think this would still work, but it has been delayed because of COVID. But I plan to implement that. I feel that should work to a good extent. Anyway, thank you.
thank you.
Thank you so much.
You are a non-ratified member, so we won't be marking you. Next person. Shrishti Mishra. ये सब नहीं है क्या? All these people?
No.
Satish Chadda,
No.
Shrishti Mishra, Sahitya Gineni. Finish very fast.
Dr. Paul is there?
Dr. Subhankita Paul. No. Dr. Sheetal Divate. Divte. Yes, sir. Who's there?
Dr. Sheetal Dute.
Okay, come please.
Good morning, everyone. My today's title is Study of Etiology in COVID-19 Associated Rhinoorbital Cerebral Mucormycosis, that is CAROCM cases presenting at a tertiary care center, a retrospective observational study. Mucormycosis is an aggressive opportunistic fungal infection, also known as phaeomycosis or zygomycosis, with a high risk of mortality. The spores of the fungus are inhaled through mouth and nose, but infection rarely occurs in a person with intact immune system because macrophages phagocytize the spores. An immunocompromised individual is unable to mount an effective immune response against the inhaled spores, leading to germination and hyphae formation. Thus, the infection most commonly in the sinuses and lungs. When the fungus invades the paranasal sinus mucosa, it may spread directly to the orbit and from there gain intracerebral access. Immunocompromised patients, especially those with poorly controlled diabetes, carry the highest risk of developing mucormycosis. India's cases in COVID-19 after COVID-19 infection began around mid-March 2021 and increased rapidly, reaching a peak of more than 4,14,000 cases on May 6, 2021. The death toll also was risen. In systemic review of 101 cases of mucormycosis with COVID-19 infection, 82 were from India and the remaining 19 from the other countries. The aim of my study was to study the etiology in patients with COVID-19 associated ROCM presenting at a tertiary care center. Objectives were to find out the etiopathogenesis of mucormycosis in post-COVID-19 patients, to study any influence on the demographic profile in our hospital, and to correlate the severity of mucormycosis with clinical, radiological, and laboratory investigations. All COVID patients presented with mucormycosis not on treatment for the same, irrespective of their severity of involvement, were included in this study. Patients of immunocompromised status and those who did not give history of COVID infection were excluded. This was a retrospective non-interventional observational study with ROCM with past history of COVID-19 infection. Study was carried out at a tertiary care, fully dedicated COVID hospital in Western Maharashtra. It was carried out for 3 months, duration May to July 2021. By convenience sampling method, 94 patients were included in this study. The diagnosis of COVID-19 was based on documented RT-PCR or rapid antigen test report of nasal pharyngeal swab. Patients recovered from COVID-19 infection 3 months prior and currently RT-PCR negative were categorized as recent COVID-19. The time limit of 3 months was taken as per the widely accepted definition of post-acute COVID-19 syndrome. Materials and methods: nasal stuffiness, nasal discharge, nasal mucosal inflammation, eyelid, periocular and facial trauma, and all the symptoms were noted. Clinical examination was done wherein visual acuity and extraocular muscle movements was recorded. Where the clinical features were suggestive of ROCM, it had to be supported by nasal endoscopic findings, nasal swabs for KOH or histopathological examination of tissue biopsy. Radiological imaging was done. Proven ROCM was defined as clinico-radiological features along with microbial confirmation on direct microscopy and or culture or histopathology. They were categorized into staging by the proposed staging of ROCM. Characteristics of the patients were noted. Variables such as age, sex, history of diabetes, value of HbA1c, value of serum ferritin, staging were studied. So the time is up.
Your time is up and you haven't even come to your results yet.
I'll just fast forward, ma'am. In results, we included that. In results, we found that, ma'am, out of 100 patients, the mean age of patient was found to be 53 with male preponderance. 25.5% of the patients needed oxygen support and treatment with corticosteroids in their COVID-19 infection. Diabetes mellitus was present in about 80.8% of all patients. Orbit was found to be involved in 43.6 cases. Laterality of ocular disease as presentation showed right preponderance. Serum ferritin was found to be raised in 63.8 cases, and value of HbA1c was found to be raised in 69.1 cases, ma'am. So in conclusion, diabetes was found to be the most important predisposing factor in development of COVID-19. And we would like to increase awareness regarding mucormycosis in post-COVID-19 patients. That's why this study was conducted in Western Maharashtra, ma'am. Thank you.
Thank you. Just one thing.
Yes, ma'am.
Papers on post-COVID mucormycosis are very common.
Okay.
There's nothing new
Yeah.
in that. And in your first beginning slide, I noticed that you mentioned that there were 92 patients who had mucormycosis, of which 86 were from India, something like that.
Yes, ma'am.
So don't tell me there were only 92 patients all over the world.
No, ma'am.
What did you mean? I
No,
didn't get that.
my study was only of 94 patients, ma'am. My study itself was of 94.
No, go back to your slide.
No, according to the, yeah.
Go back to that slide. Because I particularly noted that.
Yeah, ma'am.
That's your second or third slide, I think.
This is, ma'am. I've on it.
It's not coming on the screen.
Unka वापस डालो. 1 minute. Go back. Go back. Go back.
Third or fourth slide, ma'am.
Yes, I specifically noted that and I was amazed.
Yeah.
Yes, here it is. 101 cases, systematic review of 101 cases of mucormycosis. 82 were from India, and the remaining 19. How did you do this systematic
No, ma'am.
review?
This was a paper, like this was the reference of that Singh AK in this
No, but then
in
you should
2021.
mention that
Mention that in
reference.
the
You must mention that reference
Okay,
there.
Okay, ma'am.
You know, in
I've-
a small letter or something. How
Okay.
are we to know
Yeah. That's
where
it.
you
It was
got
sixth
that
reference.
material from?
Yes, ma'am.
The impression we got was
There were
that
only 92
that
cases
there were
overall.
only 92, 96 cases,
Yeah.
whatever,
Yeah.
all over the world.
Yeah.
Because you mentioned in Iran, this
US.
France here.
Yes, yes, ma'am.
So, and I'll give you a small tip.
Yes, ma'am.
There is a TSTC going on PPT making, crash
I'll
course
just-
on PPT making.
Okay.
Please do attend it.
Yes, ma'am. It was
Because-
a bit lengthy.
For one thing, don't take it otherwise. See, our
Yeah.
job here as chairpersons and teachers and judges is that we help you to improve.
Yes, ma'am.
So, in any slide, the material has to be less, bigger font so that everyone can see. You have to talk more
Yes, ma'am.
and fast.
Yes.
And you must time yourself. You know, marks are cut for time in a paper.
Yes. So,
Thank you.
Thank you, ma'am.
She's non-ratified member. Non-ratified. Who is the next speaker?
Don't mind her, please. No. See, this is to help you improve next time.
She's not.
It is good in a way because even if they have not registered for the TSTC board, they can just peep inside the TSTC room and learn how to prepare the PPT.
No, because I am the chief instructor there, so that's why I told her. Yes. Pardon?
Advertising your own course.
Yes. What's your name?
Dr. Nilam Pawar.
Dr. Neelam Pawar, na?
Last
Okay,
one, no?
go ahead.
So good
We have
morning.
very few candidates for that
I
course.
am one of them.
You are?
Yeah.
Okay.
Good morning, judges and everybody else present here. I will be presenting on non-compliance for wearing spectacles in school-going children in South India. So as all of we know, refractive error, they account for major cause of impaired vision in most school-going and school-going children, and various community-based population studies have also revealed that refractive error are the major cause of impaired vision in school-going children. And refractive errors, they have significant economic and effect on economic and education, including poor academic performance and reduced social participation. So the purpose of study was to study the prevalence and determinants of compliance with spectacle wear among school-going children in South India who were given spectacles free of charge under School Vision screening program. So this was a cross-sectional descriptive study, and the participants were recruited from schools from Tirunelveli and Tuticorin district of Tamil Nadu, and the School Vision camp were conducted by Arvind Eye Hospital, and this project screening was done under Lavelle Pediatric Eye Care Project, which was for overall 3 years, and of the 1,29,720 children examined from 249 schools, 4,253 children had refractive error and 333 were prescribed and dispensed glasses. And on follow-up, field coordinator interviewed 648 children who were not wearing glasses, and interview was done by field coordinator at 3 to 6 months of initial dispense of glasses. So coming to result, 2/3 of participants were not wearing their spectacle at examination. All the participants were from age 5 to 15 years, and majority of them were in age group of 11 to 15 years, and 50% of them were male children. So this study revealed that at time of examination, 506 children were actually, they were having glasses with them, but they were not wearing, and 177 were even not having glasses also, and they were not wearing glasses also on follow-up. So table 1, it describes the demographic characters of all the participants.
Can you see it?
No, actually there is very detailed, this is again, even I have to cut short it. It is.
Divide it into 2 slides.
Yeah, okay, ma'am.
That is the way to do it. Anyway, go ahead.
So these were a demographic characteristic and financial status of the parents, education of the parents, locality of the participants, and fathers and mothers' occupation. So on analysis, all these factors, they were not significantly related to the compliance of the glasses. The glasses, this table shows about the glasses wearing time period, that out of total 506 children who were sometime wearing glasses, 240 children, they were wearing glasses for 8 hours, 183 were wearing in school for 4 to 8 hours, and 58 children, they were occasionally wearing glasses, 25 were wearing less than 2 hours. The most common reason for not wearing glasses was headache or watering. Second cause was breakage of the glasses, and third was friends teasing. While vision not improving with glasses and fear to use spectacles were the least responsible classes for not wearing glasses. So coming to conclusion, lower compliance with increasing age has been reported in 3 observational studies from Mexico and Chile, and in India 3 studies have been reported with regarding this compliance, and all of the studies suggest that younger ones, they are more compliant with glasses. And in a meta-analysis by Dhirer et al. With 23 cross-sectional study, the compliance overall compliance with spectacle was 40.14%, and the main reason where non-compliance were that either the glasses were broken, forgetfulness, or parent disapproval.
You'll have to wind up.
Yeah. So coming to conclusion, compliance with spectacle wear is even poor even if they are provided free of cost, particularly in children with age group of 5 to 15 years, and factors like type of school, parents' income, their locality, occupation and education were not significantly affecting the compliance of spectacle wear. So proper encouragement and counseling of the parents and child becomes extremely important. Thank you.
How would you encourage wearing of glasses? What is the remedy? You've given us the problem.
Yeah.
What is the solution?
So we have to actually counsel the parents, because this project was done under a Lavelle eye care project, which was for almost 3 years duration. So in this project, we were even educating the school teachers. School teachers were actually, they have done the school screening, and on the children who were actually called for checkup, parents were also called for, and we have so many educational talks, CME for even CME for school program for headmasters, school faculties. So by this we can aware the awareness, but mainly the awareness was for teachers and
It should be for
Head
parents.
maintenance. Yeah, so parents, only the parents who were, if children were having defective problem, then only parents were called. Those children who were not having any refractive error, then parents.
Obviously. Why would you call them?
Yeah.
There's one more.
I'll tell you something. The main reason, what I feel behind children not wearing glasses is very often us. We ophthalmologists, when we get a patient, a child who's accompanied by his parents, we don't emphasize the need to wear glasses full time. We tend to take it very lightly, and we tell the parents also accordingly, because we don't want to scare the parents. But I think we should scare them. We should say constant wear. See, if there is a refractive error of minus 0.5, minus 0.75 in a child who's aged 5 or 7 when he comes to you, why don't you recommend using the glasses full time? Why should you say use it only part time? Because then the part time becomes hardly any time. This is my observation from my years of being in practice as well as working in medical colleges. It is we who are at fault to a large extent. Because parents say कि डॉक्टर ने तो बोला ही नहीं था कि सारा टाइम पहनना है. उन्होंने तो बोला था हाँ थोड़ी देर पहन लेना, पढ़ते वक्त पहन लेना, स्कूल में पहन लेना, और जब स्कूल जाता है तो बच्चा स्पेक्टिकल्स अपने बैग में रख देता है. And the teacher doesn't know about it, that he is supposed to be wearing glasses. Yes, but you are right that the teacher is a very important link. Because if the teacher tells the child to wear, he will wear. Even more than the parents.
More than the parents.
So that is a good project that you all are conducting.
There is one more point. The major finding was of not wearing is headache and watering.
Yes.
So is there anything wrong in the refraction or wrong
Yes.
spectacles were given? Because like it should not be there. No headache and watering if you are giving
See,
it for that
They are
purpose.
saying, they are complaining, so
No,
we don't
but then
know.
did you all investigate why that complaint is there?
No, that investigation that we
Why
have
not?
not, because we have not
Yeah.
gone back and see the analysis that how much was the power, whether it was low refractive power, whether it was low refractive.
She has a point.
Yeah. So that thing we have
See,
not.
the child's problem should go away
Yeah.
after wearing spectacles, not remain with headache and watering.
Yeah.
No child is going to wear spectacles.
So that's what, that we have not analyzed, that whether it was the initial time when they were given glasses, that time they had that complaint, or after wearing for 2 or 3 months, we have not done that detailed analysis, whether it was the initial time when we have prescribed the glasses, that time child was having headache, or after wearing for a long time. If he is wearing for a long time and then having headache, then maybe it can be because of
So, maybe going into the reasons for not wearing glasses and rectifying them can be your next paper.
Yeah.
Can be your next project.
Okay, thank you.
Thank you. Are we done? That's it? Good. Good for us. Who's? Third तो
हो चुका है लेकिन प्रेजेंटर वो चेंज को-author
so that's okay. That's okay. That's all right. I think that is matter. But yes, please do take a photo.
I think all the presenters they also can come on the stage since we have time, we can take a group photograph. No, ma'am?
Yes, yes, of course. Just let us tally the marks.
I'll stand here.
We finished before time, I think.
Yeah, much before.
So many.